Thank you, Alina, for the most kind introduction, and thank you, Jeff, Jorn, and the scientific committee, not only for the invitation, but also for the organization of such a timely conference, because it's clearly a multidisciplinary and multi-stakeholder approach that we need, and I think it's more than timely that this is organized in this way. Now, one of those aspects that is, and I thank you for bringing it also in the program, is the connection between the liver and the heart. Now, these are my disclosures. Now, you asked me to talk about the liver-heart axis. I'm going to start a little bit in the opposite direction, just to highlight that there is also a role for vascular mechanisms in the progression of liver disease, and especially NAFLD. So it's not just liver going to the heart, it's also a little bit, not specifically the heart, but vascular mechanisms also going to the liver. So the arrow goes in the two directions. But just very briefly, we know that there are structural alterations already occurring very early in liver disease. These are vascular corrosion castings. So here you see, try with the pointer, this is the normal sinusoidal architecture. This is what you observe when you have already frank steatosis but not steatohepatitis. So the structure is already significantly altered. It's not just structural, it's also functional. Mainly the endothelin pathway. There's an increase in intrahepatic vascular resistance early in disease, so this is not end-stage liver disease, it's early in disease. And you can modulate that, for example, with bosentan, and then you see that structural alterations are less pronounced, and also the histology of the disease is better. Another example is about platelets. There are several data out there. I cannot show you everything. It's just a teaser I wanted to give you, but we know that platelets are increased in the livers of patients with NASH. They're also more active, these platelets. And in a small pilot trial, these patients were given anti-aggregant therapy, and you could see a reduction in liver fat and also in other indicators of liver disease. So just a few teasers to show you that in the pathophysiology of NASH, vascular mechanisms play a role, and most importantly, the drugs that are used to prevent cardiovascular disease or to treat cardiovascular disease, they will not cure NASH, but they have interesting properties, and they can also have a benefit on the liver disease as such. Now, coming then to what I would ask to cover, it's the role of NAFLD in cardiovascular disease. There are, of course, as we already learned from Zobert, the most important, or most, in terms of numbers at least, most important cause of death in these patients is cardiovascular disease and non-liver related cancers. Of course, also liver disease in the more advanced patients. Question is, of course, is this just because of shared risk factors, or is there a specific role for that? And as we learned also from Zobert, there's of course progressive liver disease, but potentially NASH also contributes to cardiovascular disease, and also I'm sure Ken will talk about the dual role between, or the bidirectional role of diabetes and liver disease, fatty liver disease. So that's something that we need to take into account, that there are extrahepatic manifestations, but consequences of fatty liver disease. Now, we can say that, but do we have data to support that vision? And there's a lot of preclinical data, of course, but do we also have clinical evidence? And that's not so easy. There are numerous issues that make it a little bit difficult to answer that question really beyond any discussion. Because we are looking, of course, at clinical cardiovascular events. And what is that? Is that myocardial infarction, angina, patients undergoing coronary revascularization, ischemic stroke, heart failure, lesions of the valves, arrhythmia, so also the conductance system is impaired. So that are real clinical events. But you also have subclinical cardiovascular disease, by which we understand that there are lesions of the cardiovascular system, like an increase in the intima media thickness of the carotid arteries, for example, or the presence of atherosclerotic plaques, which do not translate into clinical problems, but are predictive of clinical events later on. And that's what we are calling subclinical cardiovascular disease. Now, what we have as data is coming also from some meta-analysis, and those meta-analyses also always come with some methodological issues and points of discussion in terms of the quality of the data and the quality of the studies included. But in general, what several meta-analyses have shown is that for NAFLD patients, if you make a correction for several common risk factors, your odds ratio of having a cardiovascular event, and here we talk about the clinical event, is significantly increased, and in this meta-analysis it was about 1.6. When we come to subclinical cardiovascular disease, there's some more evidence there. As I said, you can look at different lesions like the carotid intima media thickness. You can, on a CT scan, calculate the coronary artery calcium score. You can do some functional tests. So there's a whole bunch of markers that you can study to have an idea about the performance of the cardiovascular system and some alterations that might be predictive for clinical events later on. Now, this study shows you a little bit. It's one study, but the overall impression you get from all the data that are out there is more or less synthesized in this cartoon. If you, there's an analysis of the Framingham Heart study with a prevalence of 17% of NAFLD in that study. If you look at real cardiovascular events, there's a trend, but it's not always clinically significant. If you look into subclinical cardiovascular disease, here it was the coronary artery calcium score, there was clearly a significant correlation between having NAFLD and having these lesions if you correct for other parameters. So the evidence for clinical cardiovascular events is perhaps more conflicting. For subclinical cardiovascular disease, we have less conflict in the data and more convincing evidence that it is something real that we are looking at. But as I said, there are many methodological issues that we need to take into account, and we're living in a very polarized society overall across the world, and it just depends on where you stand and how you want to use the arguments. But we need to acknowledge, of course, that in all those studies, clinical studies, it's not always very easy because the definition of NAFLD depends on the method that you use. Also, what kind of clinical cardiovascular disease points are we taking into account? What kind of subclinical cardiovascular disease are we taking into account? How is it measured? So all these methodological issues play a role in the interpretation of the data. That's why I say the global, what comes out as a global conclusion from the data so far is that for clinical cardiovascular events, we have a strong signal. For subclinical cardiovascular disease, the data are probably stronger to really say, okay, NAFLD is contributing independently to the development of all this. Now, if we accept that kind of global conclusion, then several new questions come up, of course. First of all is, yeah, okay, if that's true, how can we explain it? Do we have some plausible explanation for that? And then second, is this just NAFLD, or is this more related to the steatohepatitis, the more severe subtype of the disease? And does it have, in the end, any impact on our management of the patients? Now, the pathophysiology of that liver axis, you can say, okay, there is no arrow from the heart to the liver, it's just common risk factors. And of course, these common risk factors for both NAFLD and cardiovascular disease are there, for sure. The diabetes, the metabolic syndrome, the obesity, that's quite obvious that these are risk factors for both conditions, and the systemic inflammation is a kind of common background for all of this, so that's sure that there is some common background for both diseases. But the reality is far more complex, and I like this scheme because it illustrates how all these different organs are interconnected multidirectionally. It's not just, of course we know that adipose tissue dysfunction is an important player in fatty liver disease, but there's also the link with diabetes, and there is a link with the cardiovascular system, and it's not just an arrow in one direction, it goes in two directions, also for the adipose tissue, also for the gut, also for the pancreas, and so you get a very complex system of multidirectional interactions, probably more or less vicious circles, that once they are turning, they are just reinforcing one another. And I'm a hepatologist, so I like to put the liver in the center. That's a small bias I have, but anyhow, there's quite substantial evidence to tell you that, especially when the liver is chronically inflamed, it's one of the important drivers of these vicious circles. And in the end, for a patient, it's probably not that important to know exactly where it starts, because when it starts, it's turning. And also when you need to treat it, you're not just taking one point to treat it. You just have to stop these vicious circles turning in one direction, or you have to make them turn in the good direction. So that also makes it very difficult, especially in clinical research, but also in preclinical research. If you just want to take out one of these arrows, and in this case, the arrow from the liver to the heart, if you want to prove that this is an independent one, you're getting a little bit in trouble, because there are so many other factors that play a role that it's nearly impossible to say, okay, this is really an independent arrow, dissected completely from all the other ones. If we then, anyhow, have a look at that single arrow, what kind of mechanisms could be at play? They are summarized here. I'm, of course, not going into detail because I was not given a half day for this talk. But, of course, the liver in NAFLD is releasing a lot of molecules, hepatokines, angiogenetic factors, inflammatory mediators that all play a role. One of the important factors is, of course, the lipid profile. The liver is very important in the production of cholesterol and the lipoproteins, and we know that in NAFLD the production of these is altered. So in that atherogenic lipid profile, the liver in NAFLD is playing an important role. As I said, there are other factors like angiogenic factors that are increasingly produced by livers in NASH and NASH with fibrosis. Also prothrombotic factors, especially PI1, is related to the severity of the disease. So all these mechanisms contribute to the link between the liver and the cardiovascular system and help you understand how a chronically inflamed liver in NASH can contribute to the development of cardiovascular disease. But again, this is a very complicated system, multidirectional interactions, so it's very hard to prove just one unidirectional arrow out of this complex system. So if we want to really prove it, we need far more research than what we have available now. Is it just steatosis or is it NASH? Again, it's a very difficult question to answer because the diagnosis of NASH, especially in patients, is not easy, and still the gold standard is a liver biopsy. So you are always ending up with small studies to prove this kind of interactions, which is in the cardiovascular field. Let's say it's a little bit difficult to prove whatever you want in the field of cardiovascular disease if you have just small numbers of patients with all the methodological issues of your correct diagnosis. Just a few hints. We learned from this cartoon that is shown in almost every meeting on NASH, I think, that the overall mortality, not just liver-related mortality, which is more related to the more advanced stages of the disease, but especially in the earlier stages of the disease, you still have increased mortality, overall mortality, mainly cardiovascular mortality, and that increases even if you have minor stages of fibrosis. Now, fibrosis does not fall from the sky. There is a driving force behind it. It's the steatohepatitis. So it's an argument here to say that when it's fibrosis, it's also the driving force of steatohepatitis that is here at play, and not just blunt steatosis without any damage and inflammation in the liver. Meta-analysis can also help, again, with all the methodological limitations of that kind of meta-analysis. Smaller studies, a smaller number of studies, but you can see here that the presence of NASH was associated with a 2.6, not a 1.6 for NAFLD, but a 2.6, so a clearly higher odds ratio for a cardiovascular event in a meta-analysis. But with studies that, of course, need a liver biopsy for the diagnosis of NASH. So my global conclusion on this is that it's more the steatohepatitis NASH than just the blunt steatosis that is here at play. Now, our impact on clinical practice can be summarized in 4 questions, I think. First of all, if that liver-heart axis is important, do we then need to screen for NAFLD as one of the cardiovascular risk factors? The other way around is easier. If you have a patient with NAFLD, should we screen that patient for cardiovascular disease risk factors? Or should we perhaps do more than that and not just look at the risk factors, but clearly look, or more in depth look, whether there is cardiovascular disease in this patient, subclinical, but disease. And in the end, does that also have an impact on the treatment of our NAFLD patients, and can NAFLD treatment also improve cardiovascular disease? Screening for NAFLD, of course, it's still intensively debated subject, whether we should screen for NAFLD or not. I'm just highlighting here the guidelines from EASL, ASD, and ESO from already almost 6 years ago that tell you that in subjects with obesity or the metabolic syndrome, we should screen for NAFLD and go for case finding of advanced disease when there is a high risk. And also in patients with type 2 diabetes, we should look for NAFLD. That's what these guidelines say. So these guidelines are not including the word cardiovascular disease in terms of screening. In the more recent patient guidelines, and I had the honor to chair the team that wrote these guidelines, we went a little bit further and we included that people with cardiovascular disease need to be screened also for non-alcoholic fatty liver disease. And also in the Belgian guidelines, we included not just patients with metabolic syndrome or components of that, or patients with diabetes, but also patients that had a history of an ischemic cardiovascular disease, that they should be screened for NAFLD. The question the other way around, if you have a patient with NAFLD, should you screen for cardiovascular disease risk factors? I think there is not much discussion there. I think the guidelines from virtually all scientific societies agree on that. And here you see again the EASL guidelines from a few years ago telling you that cardiovascular complications, okay, they dictate the outcome of NAFLD patients, and screening of the cardiovascular system is mandatory in all persons, at least by risk assessment. And also in persons with NAFLD, we should screen for the presence of diabetes. So that's an easy one. A little bit more controversial, should we go, as I said, a little bit further and not just look into cardiovascular disease risk factors, but really also do an effort to see whether the patient has already subclinical cardiovascular disease. I think, to make a long story short, there are no guidelines about that. You can discuss it. But first of all, we do not have a lot of cost-benefit data here to substantiate any recommendation. Question is also what kind of technique will you use, the carotid intima media thickness, functional measures, ultrasound. There are methodological limitations with all these techniques. And should we do it in all NAFLD patients, or should we just do it in patients with NASH or more severe NASH? So you can discuss about that. Personally, in my center, we do it in patients with biopsy-proven NASH, and we have a center-tailored approach. As I said, there are no guidelines, although I must say that if you read carefully the EASL guidelines, they say that you should screen the cardiovascular system, at least by detailed risk factor assessment. So they do not tell you that you should stop there. You can do more. It's not limited to just risk factor assessment. It's at least. So it opens the door for something more than that. So I think it might be worthwhile the discussion at the end. Again, in the Belgian guidelines, we included that in patients with NASH, we should go a little bit further and have a more detailed cardiovascular assessment with cardiac ultrasound and some tests for non-invasive subclinical, non-invasive tests for subclinical cardiovascular disease according to local expertise. A special word in the context of liver transplantation, because we know, as we heard from Zubair, that this is, of course, an important indication for liver transplantation, if it's not the first one. One of the issues is that when these patients come to the point that they have an indication for a liver transplant, in general, compared to some other indications, they are older, they have more comorbidities, sometimes precluding a liver transplantation. So they undergo a lot of investigations pre-transplant. And if at that time point, and only at that time point, they are thoroughly investigated for cardiovascular disease, in many instances, cardiologists will recommend to go for a coronarography. And then you discover lesions, they got a stent, they get antiplatelet therapy, anti-aggregant therapy, and then you are, for 6 months, 1 year, in trouble for a liver transplantation. So we should do that way up front and not wait until these patients get to the point of needing a liver transplant. Then briefly something about treatment. Treatment, of course, of this disease should take into account the complex scheme that I mentioned, and is simplified a little bit here. So again, fibrosis does not come like that without any reason. There are upstream drivers of damage and inflammation in the liver, but also outside the liver, and that is important to take into account for the treatment. Lifestyle modification and weight loss, it works for the liver, it works also to improve your cardiovascular outcomes. It does not mean that the improvement of the cardiovascular outcomes comes via the improvement of the liver, but it refers to what I said, everything is connected. The vicious circles are turning in one direction, make them all turn in the other direction, and you will improve on several of these diseases at the same time. Something about drugs, just 2 examples of drugs that have a benefit for the liver, but also for the cardiovascular system. The GLP-1s, I think I do not need to talk much about the mechanism of action, but it has a clear improvement on body weight, glycemic control, lipid profile via several mechanisms. We know that these drugs improve cardiovascular outcomes. That has been convincingly shown in patients with diabetes and patients with obesity, where they have been used so far. And we have data now that it also improves the liver. The best data are coming from semaglutide, a large phase 2 trial, a year and a half of treatment with paired biopsy, showing a clear beneficial effect on the liver in terms of NASH resolution. And as you would expect from these drugs, they also improve the metabolic profile with improvement in body weight, glycemic control, lipid profile, and so on. So improvement in the liver condition and improvement in cardiovascular disease risk factors. Another drug that also has results in the same direction is lanifibranor, a pan-PPAR agonist, tested in a phase 2 trial with paired biopsies. Here treatment duration was 6 months. And also here there was a clear benefit on the liver histology, NASH resolution, fibrosis regression, the combination of both, a dose-dependent effect, as you can see, but also an improvement in cardiovascular disease risk factors. An increase in HDL cholesterol, a decrease in triglycerides, it was neutral on the LDL cholesterol, an improved profile of the apolipoproteins, reduced systemic inflammation markers, and improvement in glycemic control. You see here fasting glucose and fasting insulin. So again, a drug that improves the liver condition and also has an improvement in cardiovascular disease risk factors. Whether that translates also in improvement in cardiovascular disease outcomes on the long run is, of course, something that needs to be proven, but therefore you need studies that are way larger. In the interest of time, I will probably skip this about some drugs that we need to be careful with from a cardiovascular point of view and come to my conclusion. So I hope, first of all, that I could point out to you that vascular mechanisms also play a role in the pathophysiology of NAFLD, and that some of the drugs that we use to prevent or treat cardiovascular disease are also beneficial for the liver. But again, the other way around, NAFLD contributes to the development of cardiovascular disease, probably more NASH than blunt steatosis. Pathophysiology is very complex, so we need more study to understand how this really works. But it has implications for our clinical practice. We need to screen for NAFLD in some patients, and especially also in patients with cardiovascular disease. I think it's advisable to do so. We will screen for cardiovascular disease risk factors, at least in our NAFLD patients, and treat these risk factors. Probably in some patients it's advisable to also look into cardiovascular disease as such, and especially when patients go further down the line and are approaching the point that where they might need transplantation. We should really do that early enough in order to be way on time. And as I said, for some of the drugs that we are now exploring for their utility in NASH, there is also a cardiovascular benefit, at least in terms of risk factors, and probably in the long run also on the true clinical endpoints. And we definitely need to take also that into account in our design of clinical trials, which is not easy on another subject, but that's a final note I wanted to give away. Thank you.